Are we on?
Yes, sir.
Yeah. So I think just 1 minute. Yeah. Okay. Now we are on YouTube.
Yes, we are.
Okay. So we will be having, like Varsha said, we'll be having orthodontists also in the audience. So welcome to the CIMS webinars. So 3 more minutes. Abhilasha,
Yes, sir.
you can just speak about our future programs also, about CIMS.
Right, sir. Right, sir. So today we'll be having a talk on bilateral sagittal split osteotomy by Dr. Latha Rao. Then we have upcoming webinar which will be on malunited fractures of the maxillofacial region, COVID times malunion galore. This will be by Dr. 11. This is tomorrow 11 a.m. This is our schedule for the upcoming days. Then we have after 11 we have on facial aesthetics. So please do join us at 11 a.m. This is the QR code for the YouTube channel of our YouTube channel of CIOMS. So you can subscribe as well as please don't forget to hit on this bell icon so that whatever videos are uploaded, you will get a notification about it. You can scan and directly go to our YouTube channel. So today we have Dr. Latha Rao with us. I think, sir, we can, in just another 2 minutes, we can start, sir.
Yes. We have Dr. Usha Shinoy, head of the Department of Orthodontics from BSPM, who has joined, and Dr. Ranjit Gandhi. I always see him. Dr. Shalini, so many more. Thank you all our respected participants who have never failed us. Thank you very much. So I think we have another minute. So the thing is that this time we have the polls which we have included for the Women's Week webinars, and we are going to have 5 separate polls for this or quizzes, as people would like to call it. So we have 5 separate polls, and Dr. Latha would be leading us into those quizzes. For the benefit of our YouTube viewers, I will read out the questions because you cannot see the poll. Okay. So I'll read out the questions. This poll is due to, I don't know, maybe it's something.
Latha ma'am, you could possibly show the question as well. It's there in her PPT, sir.
Okay, yeah. Then it will be visible, sir.
Yeah, I have the questions on my PPT slides as well.
That's good.
Yeah.
That's the difference this time, and it's a very good thing because we really get to know objectively as to where what we should do for our cases.
Reena ma'am has joined us.
Yes. I think the ortho department from VSPM has joined. We had circulated this locally at GDC also and other colleges too. So it will be a good audience this time. And I think we can start. Varsha?
Yes.
Varsha, the stage is yours.
Yeah, I'm just stopping my share.
Yeah.
Right.
Okay.
Good morning. Good morning all. The eminent speaker, Dr. Latha Rao, the moderator, Dr. Shruti Rao, the eminent participants, orthodontists group, and all the student participants. I welcome you all to this 27th webinar and another addition to our WWW, that is Women's Webinar Week. This is a new concept which our team has come up with and people have appreciated it. Today, the very good topic of bilateral sagittal split will be covered by Dr. Latha, who is expert in this topic. The moderator is Dr. Shruti Rao. She is BDS from Mumbai, and she holds the, at present she is working as associate professor in oral and maxillofacial surgery at Rungta College of Dental Sciences and Research at Bhilai. And she is a consultant at VY Institute of Medical Sciences, Raipur, Chhattisgarh. She has a degree of professional diploma in clinical research, and she is qualified for the fellow of Indian Board of Oral and Maxillofacial Surgeons. She is a multifaceted personality. I would like to start with what she has done at the schooling. She was a very eminent guide, the part of guide schooling. There is a guide group, and for that she has achieved a lot. Then she is having work in the tobacco control, and she manages a web page for the habit control that's creditable. Dr. Shruti is having this additional things. Apart from her academic contribution, she has eminent interest in the oral oncology, cleft, orthodontic, and distraction. She has worked in the various hospitals as a fellow, and she has presented the papers at both international and national forums. She has publications to her credit. So we welcome Dr. Shruti Rao. I remember her talking with her in conferences about the academics and even about the women in the oral and maxillofacial field. We welcome Dr. Shruti Rao to this forum.
Thank you so much.
Thank you for joining us.
Thank you so much.
Thank you for joining us.
It feels
now I hand over the proceedings to you.
Right. It's a great honor to be introduced by somebody as senior as Varsha Madam. Thank you so much, ma'am. And I'm really thankful to the entire team for being part of this event. I now take the, it's a real big task to introduce our speaker for today, Dr. Latha P. Rao. Madam is an MFDS RCPS from Glasgow, MOMS RCS from Edinburgh. She holds the International Fellowship, the IBSCOMS. She is an IBOMS as well. She is a consultant at Aster Medicity, Kochi since 2014. She previously worked in Amrita Institute of Medical Sciences from the year 2003 to 2014. She did her BDS and MDS from the Government Dental College Trivandrum. She was a rank holder in the Kerala University. Wow, it's immense to see how much one person can hold together. She has over 16 publications in PubMed, which are internationally indexed, and almost 200 citations. That is something I looked up. She gave us very little information when we asked her for an introduction. So yes, her fields of interest are orthodontic surgery and cleft and craniofacial surgery. She has been a speaker in various national and international association conferences. She regularly holds hands-on workshops in maxillofacial trauma, orthodontic surgery, and distraction osteogenesis. Madam is a wonderful person and a perfect example of skill and compassion working hand in hand. She is a treasure house of knowledge and experience in this field, and still she remains so down to earth. It's a real honor to have you speak to us today, ma'am. So buckle up, dear friends, and get ready to take off on this journey of bilateral sagittal split osteotomy. Be sure not to miss the poll questions which will surprise you at different points during the session. So let me quote Martin Fisher. He's an American physicist. He said, knowledge is a process of piling up facts, and wisdom lies in their simplification. So here we are, postgraduates and professors alike, looking forward for assimilating knowledge and thereafter gaining some wisdom. Over to you, Latha ma'am. Ma'am, your mic is muted, ma'am.
You are muted, madam.
Yeah, fine. Am I
Latha,
audible
you need
now?
to unmute
Yes,
yourself.
you are.
Yeah, I thank Dr. Shruti for the nice, kind introduction. And let me start sharing my screen. We'll straight away go into the presentation. At the outside, let me thank the CIAOMS and my dear friends, Dr. Rama, Abhilasha, Dr. Vrinda, Madhumit ma'am, and Varsha ma'am for giving me this opportunity. The Women's Week webinar is a fantastic idea, and I'm literally following up all the lectures which are given by the CIMS. They cover the vast majority of the topics that is there in the oral and maxillofacial surgery. So again, thanks once again. So coming to bilateral sagittal split osteotomy. Yeah, the outline of my talk will be like, I'll be talking very briefly on the history, a little more in detail about the procedure, but my main focus is going to be the complications and risk factors. Not the complications and risk factors per se, but how to anticipate and how to prevent with literature support. Is my cursor visible?
Yes.
Yeah, okay, fine, that is good. So the history, when I started looking into the history for this presentation, I came across two very nice write-up by none other than Hugo of Vegas. One in the latest textbook by Naine on orthodontic surgery. The introduction chapter, orthodontic surgery, a life's work, is given beautifully by Vegas. And then he also authored an article in the Clinics in Plastic Surgery, where he gives the history of the tales of three procedure, how they came into being. The wish to correct deformities and look good has been there with the mankind for long. And mainly it's centered around the mandibular anomalies, which are more visible or the most glaring deformities on the face. And all the wish to correct, the developments all led to the field of corrective surgery. When you look into the history, many names coming up, that is Julian, Blair, Costeca, Shusharts, who did a lot of procedures on the body and the angle or on the ramus at various point of time. But it is with a certain person that the technique of bilateral sagittal split osteotomy came into being. A powerful imagination generates a new event, or I would say a new surgery. Obvious describes fondly how he used to sit for hours with dry mandible and perform procedures after procedures, osteotomy after osteotomy on the dry mandible, hoping to find out a technique where he can avoid an extraoral scar and be gentler on the inferior alveolar nerve. In the end, in the 22nd April 1953, he succeeded in performing the first bilateral sagittal split osteotomy as we know it today. His boss, Dr. Trauner, at that time did an inverted L osteotomy on the right side of the mandible and handed over the scalpel to Avegesa, who did a intraoral sagittal split osteotomy. These pictures are from his chapter and of his first patient. It shows how the tissues are reflected, how the cut is placed, and how the split has happened. And this is the patient immediately post-op, and the same lady after 33 years of the surgery. The indications for BSSO It's like many-fold. You can, as Vega sir has explained, it can be used for setback, advancement, or even for correction of the asymmetries. The beauty of the procedure lies in its versatility because of the good bony overlap which we get between the proximal and the distal segment. Here we'll be using the proximal distal segment to explain the bony segment. The proximal means the one closer to the body, the one with the condyle, and the distal is away from the body, that is the one with the dentate segment. So this is the proximal and this is the dentate segment. Then again, Obvious' procedures too underwent a lot of modifications in the hope of developing newer, more safer, more reliable, predictable techniques with less relapse. And the description by Bachman in PRS 2014 gives how the modifications of Obvious BSSO came into. And we'll take the first poll question here, which is the most commonly practiced BSSO technique worldwide. I want all the audience to make a note of the question and the answer. I'll read out which is the most commonly performed BSSO technique worldwide. Here, option A will be Troner and Obvious, B will be Dalpont, C will be Hansak, and D will be Epker. Yeah, this is poll 1, Dr. Rama and Dr. Varsha.
Yeah.
Yeah. Do the audience have to mark?
We've got a good percentage polling.
Yeah.
So I think the YouTube people would unfortunately not be able to see the poll, but they can see the slide, which has got the questions on it. So
Nor will be able to answer.
that is something which is not really in my hands.
No, that's absolutely fine, sir. But today at least they can see the questions on the
Yeah,
screen.
so we've got a good percentage, Abhilasha. We've got 63%.
62, yes.
Yes, sir.
Looks
Yes, sir.
So we've already hit we are already in first.
Yes, I think we have.
Yeah.
No changes now.
So shall I proceed?
Dr. Latha, I will just share the results.
Okay, fine. Yeah.
Maybe you can discuss a little bit on that, right?
Okay, fine.
This is the result. So 53% have polled for Troner and Obvigizer in 1957.
Yeah. So the results are in front of us to see. The Troner and Obvigizer leads the show by 53% of votes, followed by Epker in 1977, Hansak, and then in the end by Dalpont. Yeah. Shall we go to the answer now?
Yes.
Yeah.
Yeah. So that was the poll 1 question. And what could be the answer? The answer is C, that is Hansak's modification. Yeah. So as you can see from this diagram, I'll explain a little bit. The one I'm showing here is the technique by the Obvious. He goes all around till the posterior border of the ramus, and anterior osteotomy is much more distal than the second molar. Where you come into the Hansak modification, you can see the medial osteotomy, that is on the medial aspect of the ramus. The osteotomy stops at the lingula. And the anterior osteotomy, which was distal to the second molar in Obvious technique, has been carried forward to the region of second molar, or even the area between first molar and second molar in the Hansak modification. We'll see why these are important as we go by in our presentation. And one word about Epker modification. He is the one who advocated minimum soft tissue dissection on the medial aspect of the ramus to protect the nerve, and as well as minimal dissection of the muscles of the bone so that you can protect the bone from the ischemia. It is the tergomesenteric sling which provides vascularity to the mandibular ramus region. The rest of the mandible gains blood supply or nutrition from the inferior alveolar nerve and the vasculature. but the ramus, the portion posterior or distal to the inferior alveolar canal, gains their vascularity from the musculature. So you have to be very careful when you do dissection of the muscles away from the ramus. So it's a small video which shows the the BSSO technique, the Hansak modification. This is the lingula on the medial part of the ramus. And the medial cut is just above the lingula. And the nerve entry is over here. This is the medial cut, medial osteotomy cut. And this is the oblique cut, which goes along the external oblique ridge. But you see there is enough bone on the outer lateral surface. And as you turn the mandible, you can see a bulge on the lower border of the mandible. That is the area where there is maximum thickness of bone. And the nerve at this point lies midway between the buccal and the lingual cortex. So your vertical cut on the buccal side is just beyond that. That will correspond approximately between the second and the first molar. So our osteotomy has a medial portion, an oblique portion, and a vertical portion. This is the oblique portion. You need to have enough bone on the lateral aspect, that is just medial to the external oblique ridge. So you start with your osteotomy on the medial aspect. And as you can see, it's beyond the lingula, there is a flat surface here. It is still that area you need to take your osteotomy in so that the splitting happens naturally. So the medial cut is being performed. And then you come onto the oblique part of the osteotomy. That is the second cut. Either you can do a complete one-stroke cutting, or you can put multiple postage stamp. You can do postage stamp technique as well. You drill multiple holes and then you start connecting them. And the idea is just to enter the cancellous bone. The depth shouldn't be beyond 7 to 8 millimeter. That is enough to reach into the cancellous bone, beyond which you will have to be really careful about the nerve. So if you are using a 703 or 701 straight Fisher SS white burr, one burr height of entry into the bone is sufficient. That is about 7 or 8 millimeter. So here we are putting multiple puncture holes and connecting them. And when you come onto the labial cortex, that is in the vertical osteotomy cut, it has to be perpendicular to the bone and between the first and second molar. Here again, the depth of penetration you have to keep in mind of the inferior alveolar nerve in the midway. And the lower cortex has to be cut. Both the buccal and the lingual cortices of the lower border has to be cut, which you can see from here. The buccal and the lingual cortices have been penetrated in the lower border. Okay, so here I'm marking the possible. It usually happens beneath the inferior alveolar canal in the mylohyoid fossa region. This is the osteotomy cut and the lower border, and this is the medial cut. And this area is where the mandible is going to split. After your osteotomy, you gently use an osteotome or chisel to separate the cortexes. Very gentle. Don't penetrate bone entire depth into the bone. Be very gentle. Gentle taps with a person stabilizing the mandible is very important. And whenever you feel a resistance, you can see it starting to separate from here. And then pay attention to the vertical cut. It has to be complete in the inferior border. See, it has come out through the inferior border. Then you use your spreaders, Smith spreaders for the separation. You gently pry the segments apart. and it splits. And when you see on the lingual aspect, you can see the split has happened where we have predicted that it is going to happen, right? It is the area just beneath the inferior alveolar canal in the mylohyoid fossa region. And you can see the J portion of the entire lower cortex, lower border, has come onto the proximal segment. The proximal segment is the segment with the condyle, and this is the distal segment with the teeth. And this is how it's. The beauty of the procedure, like I keep on saying, is the good bony overlap that we are going to get. So this is a classical Obvegesa technique. You go till the posterior end and the split is something like this. You can see how the split has happened. But when you compare the BSSO technique, the modification by Hansak, you see the medial osteotomy stops here. While we went up till the posterior border, it stops midway in the ramus in the region of lingula or just beyond the lingula. And this is the difference. And pay attention to the J shape of the lower border, which comes onto the proximal segment, that is the segment with the condyle. The lower border, the J, comes onto the proximal segment. Okay, we'll take a question break here. Dr. Shruti, do we have some questions?
Ma'am, I had a small doubt.
Yeah.
That firstly, I really liked your video that you played for us. It's very beautiful and so lucidly explained to us.
Yes.
And thank you for that.
Yeah.
Ma'am, regarding what is your favorite technique and why would you call it so?
Yeah. From the video of mandibular cut itself, you would have understood which is going to be my favorite. It is always the Hansak because the overlap which we get. This much of overlap is what we get to when we do a advancement. And it is very easy to predict the, what do you say, the split and to get a split as well. Only thing you have to be careful in the Hansak is that the lower border cut needs to be complete. Then you get a predictable cut and it is very versatile setback, advancement, or even asymmetrical corrections. In asymmetrical correction, this modification is very, gives you all the freedom to move the mandible in all directions.
Right.
Dr. Pauline has raised her hand.
Yeah.
Pauline, can you ask your question? She raised her hand. Pauline, if you want, you can ask your question. There's one question.
There is one more question actually.
Yeah.
From GG.
Okay.
They say bad splits when we use the spreader. What can be expected? So I think they're trying to ask,
yeah,
saying when you use the spreader, would you expect bad splits?
No, it is not with the use of spreader where you get the bad split. If your cut is incomplete and then you apply undue force, that is when unanticipated cuts or bad splits can happen. So always, like I said, make sure that your burr cut is into the bone for a depth of 8 millimeter all around. On the medial aspect, you have scored the cortical bone, you have entered the cancellous bone. External oblique ridge, again, you are in the cancellous bone. Vertical buccal vertical cut also, you have to be in the cancellous bone. And when you come in the lower border, the lingual and the buccal cortex should be cut nicely. You always confirm with the chisel that all your cuts are complete and in the cancellous bone. Then you start applying the Smith spreader. And when you apply the Smith spreader, don't yank it open. You don't use force. A Smith spreader is actually, we are supposed to use Smith spreader with just 3 fingers. Gentle pressure on the 2 blades, yes, 2 handles. With digit pressure, not the palm grip. Don't do a palm grip. Just use your fingers to apply the pressure. And if you feel some resistance, see where it is. Get a good hemostasis, get a good light, see where the resistance. And if you feel that the cortex is not completely cut, you'll be able to see it and then you'll be able to chisel it out or you'll be able to drill it out. then again apply. And
Ma'am,
slowly,
there is one more question.
Yeah.
What is the exact difference between Hansak and Epker modification?
from the
Will you be
picture.
coming to that further? Or?
No. We'll leave the historical part here. So I'll try to explain with this picture alone. From
That
the
was asked by Sai. Sai has asked that question.
Yeah. From the picture, you can see almost the entire bony cut is the same in the Epker as well as in the Hansak modification. But when you search the literature, it is Epker who advised, who kind of, stressed on the need for a complete osteotomy of the lower border, which was not part of the Hansak modification initially.
Okay.
And then the soft tissue reflection on the lateral part of the ramus is kept to a minimum, so that ramus is not stripped of its vascularity. Earlier authors used to strip widely on the lateral as well as on the medial part of the ramus. But to prevent changes with non-vascularity, Epker has reduced the amount of dissection on the lateral part of the ramus.
Thanks. Okay.
Yeah.
Thank you so much. I hope that answers your question, Saiji. Coming to another question by Shruti Gunashekhar.
Okay.
She says, what are the other instruments that can be used other than the Smith spreader for splitting the mandible? Ma'am, would you try that multiple osteotomes wherein we keep two osteotomes and tap on
can
one,
be done,
and
can
the first
be done.
one
We
loses
can,
up,
we
and
can.
then you walk it over and keep
can be done, can be done. We can apply two osteotomes at two different sides and apply a little twist motion with our hand and gently try to pry open the cortices.
Okay.
But then with Smith spreader, you get so much good control.
That is true. That's true.
So
it's a beautiful instrument. Yes.
Yeah, it's a beautiful instrument, especially if you have two Smith spreader. One can be applied on the external oblique ridge, the superiormost part, and one in the anterior part. Okay. So that gives more control over the procedure. But one is good enough. You gently, even the osteotome or the Smith spreader, you gently start from one and slowly progress, gentle squeezing motion or gentle twist. See where the resistance, then progress.
Okay. Okay. Right. So shall we proceed then for now? I think we have.
Okay, fine. So proceeding with the presentation.
Coming
to the main part of our presentation, how to identify the risk factors and avoid complications. John Ferrer in 1970 has said that during any operation, a surgeon inevitably injures the patient. But this injury can be minimized or converted into a benefit for the patient by careful, gentle, and accurate surgical technique. That holds true for all the surgical procedures. So how to go about it? Know what literature says. It's always better to learn from others' mistakes also rather than from your own mistakes. So learn what the masters say in the field. Anticipate the problems. Think in which all step you can go wrong. Prepare yourself well to face them or to avoid the complications. And once it happens, you rectify them. So we have put few points together on which you have to pay attention to. In the planning stage itself, you have to start thinking how you can avoid complication. The first and foremost is like you have to decide which structure is at fault, whether it is maxilla, mandible, or both. Consider the peculiarities of the mandible, whether it's a low angle or a high angle. Check on the airway. See whether third molar is present or not, impacted or not. See the position of the nerve. Then when you come into the surgery, these are the structures that you have to be very careful. Don't traumatize the nerve. Don't create a bad split or an unanticipated fracture. And we'll see what condyle sag as we go into the presentation. And in the post-op, of course, you need to get a stable result. So in the planning stage, you start preparing well. Phase, as we know, is different for different person, and each facial feature comes with a particular type of occlusion. So if a particular face person cannot expect an occlusion like this a narrow-faced man has. You have to have that in mind first. Not everybody's skeleton or not everybody's occlusion is going to be the same. Whenever you see a patient, orthodontic patient first, it has to be with the in a combined clinic with your orthodontist around. It is a continuing process. The analysis doesn't stop on the first visit. It happens over the subsequent visits as well. You have to evaluate the patient face for its proportion, volume, symmetry, and visible deformities. But what happens when you keep on staring at a patient's face, they will become very much bothered about your stare. They will start giving you all the unnatural head positions, jaw positions, etc. So the process of evaluation, facial evaluation, happens as you talk to the patient. Put the patient at ease, make the patient relaxed. You start talking to him about his worries, about his profession, or whatever. Make him relaxed, and in the whole process, you observe the patient. If you ask me, I will say that the observation starts from the moment he walks into the cubicle, into your office room. And observe from all angles, not from a frontal view alone, but from the profile as well as from behind, from down, wherever, because you may see something which you have missed from one aspect. So always believe that there is more to what you see, and try to see it from all angles. I cannot stress more on the importance of records. You get the photographs in all angles, the lateral oblique. The lateral oblique actually gives you how the maxilla and the mandible is placed much more beautifully than a profile picture. And a bird's view and a worm's view. Take records of your dentition as well, because once the patient leaves, you might have difficulty in seeing how the teeth were in occlusion. Get the standard radiographs, lateral cleft, PA cleft, and the orthopantomogram, and study models also. Now comes the golden question. What is at fault? The maxilla, the mandible, or both? How do we decide? I have put a slide where there are 3 patients. All 3 have a concave profile, girl A, B, and C. And you would agree that all of them have a concave profile to varying degrees. Here comes our question number 2 for the poll question. I want you all to have a nice look at the face alone. That is what we have provided you right now. And say, what are the treatment plans that we would have done for these girls? So the options I will not read out and confuse. We'll take a moment. We can take a little bit of time to correctly go through the options and mark your answer, whatever you feel is right. What would be the ideal treatment plan for the patient A, B, and C? All the 4 options contain treatment plans for patient A, B, and C.
Ma'am, we have one more question actually by Anuj Dadich. I'll just wait for everyone to answer the poll, and then
because they'll have to pay attention to the answer. Yeah.
I think I've forwarded one from Anisha also to you, Shruti.
Okay, sir.
No, that's on the chat box only.
Oh, yes, I've seen it, sir. I just saw it. Ma'am, would you like to take both these questions after this poll?
Yeah, after this poll, we can have the question.
So,
okay, so all 4 options are back to back. They're all progressing with almost the same.
A little bit confusing. I have biomaxillary surgery, setback, advancement, all the different combinations that is possible.
So we have cleared the exam, but we need to at least get into a first division. Few more, please. Yeah, 64%. Very good.
66. Wow. And increasing.
Yeah, and it's increasing. I think we'll wait for another 15 seconds.
Yeah.
Before we stop it. And then I'll display the poll results.
Yeah.
Okay. So I'm just about to close the poll.
Isn't this so exciting, sir?
Yes.
Isn't this really exciting to see this progress? It's more like watching cricket or something like that.
So I will just share the results. Maybe you could discuss it, Dr. Latha.
Yeah, we will do that. We'll do that. Okay. So I have the poll results in front of me in the screen. 47% have opted for option number 1, 28% for the option number 2, and 17 and 20% for the option 3 and 4 respectively. So the correct answer, if I say that, is option number 2. Then we'll have to see how it happened like that. That is option.
Stop sharing? Shall I stop sharing?
Yeah.
Okay.
Yeah. So the option 2 is the right answer, or the procedures which we carried out for these girls. The patient A underwent a bimaxillary surgery. Patient B, a mandibular setback alone. And patient C, a maxillary advancement alone. So we'll see how is it that we arrived at that. Shruti, do we take the questions now before I proceed further?
Ma'am, would you want to complete this discussion? Because I think everyone must be eager to understand why.
Okay, fine. So coming to patient A, the girl who underwent bijaw surgery. Why was it? This is how she looks in reality when she came to us with the profile like this. Her concave profile is not too bad, but when you see her occlusion or when you see her lateral cleft, you understand how proclined her upper incisors are, how compensated they are to meet with the lower teeth which are in her head. So that gives that apparent fullness on the nasolabial angle or less of a concavity to her face. But you see, as we progressed with our pre-surgical orthodontics, the teeth which were proclined were aligned to the basal bone, we decompensated, and the negative overjet increased. So there is no option other than a bijaw surgery. Her mandible is way too forward and maxilla is way too back. So she had to undergo a bijaw surgery. And this is it. The results worsened after the pre-surgical. Her face worsened actually after the pre-surgical orthodontic. She used to have difficulty in keeping her lips closed because the lower jaw was jutting forward. The decompensation moved the decompensated lower anteriors to a straight position, and same thing for the upper incisors as well. And this is after the bijaw surgery. And to start with, prior to the pre-surgical orthodontics, when she visited us for the first time, this was her occlusion, very mild class 3, with a little bit of a crowding. In-out tissue was there for the incisors. But as we progress with the pre-surgical orthodontic, the decompensation, you see how big the negative overjet has happened. And this is immediate post-op. You can still see the sutures over here. And this is after debonding. The occlusion is stable and she is happy. So that is patient A. Coming to patient B who underwent BSSO setback alone. Again, from the lateral cleft, from the readings, you see that the mandible is at fault rather than the maxilla. So this is the procedure she underwent. Mandibular setback and an advancement, genioplasty to get her mentolabial sulcus right. This is how she looks after the procedure. So the maxilla, which looked actually, little retruded here, is the same as is here. We haven't touched the maxilla. It is a relative phenomenon. The maxillary hypoplasia, which the girl seems to be having here, was purely because of the forward positioning of the mandible. And this is her occlusion. And coming to the third girl who underwent a maxillary advancement alone. From the radiograph, the pre-radiograph, we knew that the maxilla was at fault. The measurements were done from the radiograph, and maxilla alone was advanced for her. And this is the result. After the surgery, I couldn't force her to take off her headdress for a photo. So this is it. She seems to have a better balance in the lower face between the maxilla and the mandible. The mandible, which looked very much prognatic pre-op, is now within the limit.
So there is an element of auto rotation as well, right, ma'am?
Yeah, there's an element of auto rotation of the mandible. The mandible tends to overclose a little bit.
Okay, ma'am.
To meet with the maxillary teeth. Yeah, this is a post-op occlusion.
Beautiful. Ma'am, before we move forward, I'll just communicate the other two questions which have been moved forward.
Please go ahead.
We have one question from Anisha, madam, and she asks, why prefer Hansak? When preserving soft tissue cover is useful, what would be the advantage? I think she means to say, you preserve the soft tissue.
No.
And Hansak you do.
Yeah, I explained the basic difference between the Hansak and Epker when I said that soft tissue reflection part. But now, as we do the procedure, we don't reflect the tissues on the lateral part of the mandible at all. Okay. It's a combination of Hansak plus Epker is what we do now. We are very careful in what we dissect off the bone. It's only limited dissection is what we do.
Okay, ma'am.
Yeah, ma'am.
Thank you so much. Yeah. And there's one more question on YouTube by Anuj Dadij. He says, any specific osteotome to complete the buccal cut so as to ensure that the nerve is not damaged?
Yeah, there is a curved chisel or curved osteotome. It is called Daughtry's osteotome. We'll see application of the Daughtry's osteotome as we progress. On the external oblique ridge, that oblique cut and the buccal vertical cut, you can apply the Daughtry's osteotome.
Ma'am, there's one more question by Chinnaya Ranjendran. He says self-prediction is done for the cases, ma'am. He's asking you.
Yes.
Have you done self-prediction?
Yes. I'll go through it in my subsequent slides.
Okay. Yes. Okay. Thank you so much. Yeah. Let's move.
Yeah. So again, back to the question. How do we decide? We saw that from the clinical examination alone, from a one glance, we could go wrong for all the diagnosis. So how do you decide correctly what is at fault? All of us are familiar with how to examine a face in the facial thirds, as frontal as well as from the profile. Pay attention to the relative position of the mandible, maxilla, the upper lip, lower lip, and look for the symmetry in the frontal facial fifths. I'll not go into the details, but pay attention to examining the face in thirds. So what we usually do is we observe faces, right? All of us observe faces. Whenever you see a patient, not a patient actually, whenever you go out, you happen to have some time with you, or start observing faces in these facial thirds and facial fifths. So that will give you a that you will come to do it automatically whenever you see a face, and the clinical examination becomes more and more correct. And the small trick is, when you see a patient from the lateral aspect, you can hold a small piece of paper and block out the maxilla completely and examine how the mandible is placed with respect to the rest of the face, or block the mandible completely and see how the maxilla is placed with respect to the face. So when I block the maxilla off in this girl, you can see the mandible, though it has auto-rotated a little bit, it's not too bad in position when you compare with the pointian. But whereas when the mandible is taken off from the picture, you see how the maxilla is retruded. So that is a clue as to what to do for the assessment. And second, like we discussed earlier, always be cautious about overclosure of the mandible. This girl, again, a classical concave profile. You see the mandible looks prognatic, but see her dentition as well. We actually had difficulty in taking this photograph. The upper lip was falling too far down, and see how the maxilla is vertically deficient also. Usually our incisor exposure is 0 to 2 millimeter. It should be somewhere here when with respect to the upper lip. You see it is like about 5 millimeter intruded maxilla, vertically short maxilla. So when the maxilla is vertically small, the mandible obviously has to meet the maxillary counterpart teeth. So moves up and forward. That is called overclosure of the mandible. So how do we assess? If you suspect incisor means maxilla being vertically short, check for the incisor show or incisor exposure while the patient is at rest, while the patient is animated. That is when she's talking or when she's smiling. And if you suspect or if you are kind of sure that there is an amount of mandibular overclosure that is happening, wash the patient profile when you give a small wax bite on the posterior teeth. You give something between the posterior teeth that will open up the mouth a little bit. When you open the mouth with the posterior bite opener, what happens? The mandible will rotate downwards and backwards, and it will assume more of a normal position. That is how you check whether the deficiency of the means the deformity could be because of a deficiency of maxilla or excess of mandible. Then again, a class 2 profile person, you can ask the patient to protrude his mandible and see what improvement you can obtain. This is all clinical tips which we can make do in patients. So this boy is huge maxilla, transverse excess, anteroposteriorly excess. You can see the maxilla almost up to the second premolar is transversely bigger than the mandible. So obviously we have to plan a case as to reduce the transverse width and adjust the anteroposterior excess of the maxilla and anteroposterior deficiency of the mandible. So he underwent a 3-piece maxilla and setback and a mandibular advancement. So this is how he looks. So will the clinical evaluation alone decide on ear surgery? No. You have to kind of have cephalometric values which will reinforce whatever you had made a observation in the clinical evaluation part. You can use any of the evaluations or assessments or analysis that you are comfortable with. If there is an asymmetry, you assess the frontal ceph as well. And so small, you get a certain value from one of the analysis, like there is a deficiency or a negative overjet of some, say, few millimeters. Now you don't know how to divide those millimeters between the maxilla and the mandible. The maxilla is little behind, mandible is little forward, but you don't know the distance of 10 millimeter, how to divide between the two. So it's a case you can take a piece of tracing paper, trace the maxilla alone. The maxilla, the first molar and the incisors alone have been traced on this piece of paper with lip and a part of the nose. So this is the starting position. And you advance. This is a case of negative overjet of 6 millimeter. So we are trying to find out whether entire maxilla needs to come forward by 6 millimeter or whether there is a need for mandibular setback as well. So we have advanced the maxillary paper to the class 1 or the positive overjet on that. So if you're happy with what you see, then okay, we were happy with what we saw here. So with the maxillary advancement of 6 millimeter, the patient is going to look good. This is the girl who underwent Leafoot advancement. That is patient number 3. So you understand, right? This is how we decide. So if the distance was more, so we feel that it's like about 10 millimeter or 12 millimeter, and we decide to divide 6 between maxilla and 6 for the mandible. This is how we would check whether the advancement or setback what we have decided will, how it will be on the patient's profile. Yeah. Any questions yet, Shruti?
Yes, ma'am.
Yep.
Just give me a moment. Yes. So, in the case of that female showing overclosure, ma'am, what are the various treatment options? Can you please take us through that?
Okay. Yeah, this is the case. So you make a decision of the negative overjet. It is like about a centimeter. So the advancement will have to be by about 12 millimeters. Maxilla is grossly at fault, and by measurement wise, the mandible is at normal. So the entire distance we would like to advance the maxilla to get a positive overjet and to increase the what you say that vertically shortened maxilla. You have to increase the facial height as well. So here the procedure we carried out was a maxillary advancement AP and downward by means of a external distractor.
Okay, ma'am.
Yeah.
Ma'am, another small query. What analysis do you normally recommend and why? And I just wanted to know this because...
Yeah, for me, being a surgeon, if you ask me which analysis would I prefer, it is Cox, and Cox. That is cephalometrics for orthodontic surgery by Burston. This is an article.
Do you follow some local values, or do you follow the standard original values?
We have few articles which have done for various population. There is one, I forgot the author right now. It's done for the Indian population as well as especially the South Indian population. There is a study. But then it is a comparison is what we actually do. And the beauty of Cox is that majority of the measurements are in millimeters, which are easier to translate into surgery. Correct. If you take, say, SNA angle or SNB angle, though they give us a picture as to what is at fault, whether the maxilla or the mandible, we can understand from those angles. But when it comes to the operation theater, when it comes into the patient's measurement, we have difficulties in doing angular measurements on table. So the measurements we get from Cox are linear ones, which can be kind of translated into surgery. Which are easier, like.
Okay. And ma'am, would you normally prefer to use more than one analysis?
Yes, yes, definitely we have to, because all this analysis are highly operator or the person who analyzes dependent. The points you mark, the measurements you take. Even if one person does the measurement on the same lateral cuff at two different point of time,
you will get variable.
Yeah, the results will be varied. The answers or the measurements will be different. So it's always better to do more than one or two or measurements and then compare.
Okay, ma'am. Ma'am, another question by Dr. Rahul Chajlani. He says, wonderful presentation, Latha ma'am. Ma'am, in the cases on the pole, in the second case, could a maxillary advancement be done alone in the second case?
Yeah, the clinical picture showed her as if having a maxillary hyperplasia. I do agree. That was our first, what do you say?
Thought?
Yeah, first thought also when we saw her. But then the results from the lateral cuff showed something different. Maxilla was completely normal, and it was mandible which was in excess anteroposteriorly.
Fine.
So we had difficulty in convincing the girl herself because she is a medical student. So she always thought it was her upper jaw that is at fault.
Okay.
So it was difficult to convince her the otherwise. And then when we got the surgery done, she and her orthodontist. This is not an in-house orthodontist job. We got a reference from outside. So the orthodontist too kind of said yes.
Fine.
We could convince them with the values.
Okay, ma'am. Ma'am, there is another question by Dr. Hussein Dhabaria. He says condylar position changes due to rotation of the mandible in anterior and downward movement of maxilla.
Yep. Yes.
I think he's asking it because it ends with a question mark. He says, does the condylar position change due to rotation of the mandible in the anterior and downward? When in auto rotation, you also change condyle.
Mandible will undergo a clockwise rotation. Will go down and back a little bit when the maxilla.
But the condyle as such will remain seated in the
If you
I
are
think
not, yeah,
there
it
might be a
does.
bit of remodeling, is it?
Yeah,
Ma'am?
it remodels quite a bit. Immediately post surgery, you might see the changes, but then as time goes, the condyle remodels and then takes on to a natural position, which is a most
Okay.
symmetrically positioned for the
Ma'am,
patient.
one last question for this question break. Dr. Gigi says the splint that we make, can its measurement vary with condylar sag coming into play, making it difficult to place it intraoperatively? Do you have trouble putting in your splints that you fabricate?
No, never.
Okay.
Because I do my own splints, so I know what modifications do we have to make. And
Okay.
the condylar sag doesn't come into the splint or because of the splint. We have a session on the condylar sag as we go forward.
Right.
Yeah.
Okay. So I think take home message from here is do more than one self analysis, follow both the clinical and the
And
and
when
the
you
cephalometric
get
value.
contradictory results from the clinical and the KEF, give more weightage to your clinical findings.
Okay, ma'am.
The
Okay.
SCEF values are for you to substantiate your clinical findings.
Okay,
Don't
ma'am.
operate on the lateral KEF. See the patient and the lateral KEF and then make up your judgment.
Fine, ma'am. Thank you so much.
Welcome.
Okay.
Yeah. Another important aspect which we have to pay, which we kind of forget always, is to see how the patient's airway is on the lateral KEF. When we search the literature by Wolford long time back, let me check here, 1979, he came up with velopharyngeal anatomy and the changes with maxillary advancement and the mandibular setback. And he said the changes in the airway is more pronounced with mandibular surgery than with maxillary surgery. It is because the soft palate, however much you have advanced the maxilla forward, the soft palate tries to compensate considerably to deal with the velopharyngeal incompetence. So we don't want a velopharyngeal incompetence to happen. The soft palate compensates and moves backward. So at the end of 6 months or an year, the changes which has happened on the airway because of the maxillary procedure is negligible. But the things are different when you come to the mandibular surgery. The changes in the position of the mandible will change the position of the tongue, the hyoid bone, and the dimensions of airway. And whatever changes happen immediate post-op will will reduce a little bit over 6 months, then stay put. So the reduction in the anteroposterior dimension by 28% by mandible setback reduced for about 6 months and remained at about 11% after 1 year. So more the setback, more the reduction in the anteroposterior dimension of airway. So others have kind of cautioned us against mandibular setback more than 5 millimeter because the reduction in airway will be so great as to trigger obstructive apnea in patients predisposed to apneic spells. Like these are the things which we have to look for in a patient, in an obese patient, a patient with short neck, a very small neck, chin throat angle. There is a lot of submental fat, and patients for various reasons can have macroglossia, large uvula, or excessive soft tissue in the nasopharyngeal region, say tonsil adenoids. In these cases, you will have to be really worrying if you plan to do a BSSO setback. And coming to about high angle and low angle of mandible. I've given 3 X-rays. Yeah, we are having our next poll question here.
Calling in for the poll, everyone.
Yeah. X-ray A, X-ray B, and X-ray C. My question is, which of the cephalogram shows a high angle mandible? Whether it is A, whether it is B, or whether it is C.
Ma'am, we are really enjoying your session.
Thank you. Thank you, Shruti.
We're getting a good response to the poll also.
Mhm.
So,
Participants are also enjoying these questions. The thought process is going on.
So which is the high angle mandible here? It is A, B, or C?
Still increasing. Numbers are still increasing.
Oh, okay.
Correct.
everybody can answer because you're not going to be judged by this. This is not an exam. So you can go ahead.
That takes a lot of fear of your mind, right?
I
When
know.
you can
Sir,
answer
sir,
and
do
you
you get what who answers? Do you
No,
get?
it's anonymous. We
Thank
cannot
God
pick it
for
up. So
that.
you can answer, no problem.
that is I said when nobody is going to know what I'm going to answer.
It's quite a relief, yes.
Yeah, it's quite a relief.
So we first division has been reached. I think another 15 seconds. Is that okay? I think
Okay.
it's going a bit static now.
Okay, one more
Yeah, it's
percent.
going up. Yeah, 61%.
Come on, some more people should answer it now.
Go
Fear
for it.
allayed.
The person who answers the most will get a free entry tomorrow. So tomorrow.
Yeah,
So,
we'll keep one place for you. See, all our webinars are going houseful. We'll keep one place for you, secured.
yes.
But how would you know who answered all? Got you.
Maybe the host can know.
Okay.
Dr. Rama can
I'll
tell
stop
us.
it here.
Right. Yes. Okay, sir. 64%.
Yes, and I will just share the results. Okay.
Yes. The
So
majority have got the answer right. It is the X-ray C, that is the option number 3, which has the high angle mandible. So what do you mean by angle of the mandible? It is the angle between the ramus and body. In a normal patient, this is a patient with normal mandibular angle. It's like it's about 120 degree. But when it is a low angle, you can see how the difference between a normal and a low angle case. And again, you can see how what is the difference between the normal and the high angle case. The angle has opened up. The ramus is short, the angle has opened up. So this is what makes the difference. You can see the angle here like this, and here it is more of an acute kind, and here it is more of an obtuse kind. That is what you have to look in patient when you examine a patient. Okay, we'll come back to our patient A and B, the two beautiful girls. So who is high angle in this case and who is the low angle? Obviously, patient A is the high angle case. You can see the difference, right? A short ramus and a long body, and the angle is opened up. Whereas for this girl, it is a short angle or a small angle case. So this is the difference on the lateral calf, which is more explanatory as to why one is high angle and one is low angle. And are we worried about the high angle or low angle patient? Why should we be worried? Because from the dry mandible video, we saw that the vertical height and the buccolingual width of mandible matters when you do a sagittal split. In a high angle case, it is normally seen that the height of the mandible is less. You can compare it. I have put arrow marks for the height on both X-rays. You see how different it is. And again, the mandible is narrow. And the buccolingual width is also going to be small or narrower in case of high angle mandible. So always keep it in mind that this is a case of high angle. I might have difficulty, and you have to be extra cautious when you carry out your procedure. Is that clear between the difference between the high angle and the low angle? Then proceeding with the examination part, see what you have to decide what you have to do about the third molars. It is an issue of controversy still. Some people say that you have to remove it before surgery, or some people say that it can be removed during surgery. So if you remove it along with BSSO, the advantage is there's only single procedure, and it is always easier to locate or identify the nerve with respect to the tooth. But is there a chance of getting an unfavorable split if you do both together? And if you get a split, then this is going to prolong the surgery. And one thing that needs to be paid attention is like when you after you remove the third molar, the bone stock or the crypt inside the bone is going to be hollow, and so you have less bone stock for stabilization. So these are the factors that you have to keep in mind. What is the advantage of doing it as a single procedure, and what is the disadvantage? So this is a key article by David Precious, which came into our O journal in 1998. He evaluated 1,256 mandibular sagittal splits. And there, it was a retrospective analysis, of course. And their observations said that there are more number of bad splits in cases which had undergone mandible third molar removal 6 months or 9 months prior. That is something which we have difficulty in digesting, right? You do both procedures together, that is the removal is done during BSSO, the unfavorable split is less. But if the third molar was removed prior to the procedure as a separate procedure, then there was more increased incidence of bad split. So in 2004 in the JOMS, there are two articles. One is for removing the third molar with sagittal split osteotomy, and one is against. So David Precious was very happy to mention that third molar can be removed along with BSSO. And you split the mandible, you perform the cut, you split the mandible, then the removal becomes easier. But then you have to be very cautious in removing the amount of bone which you need to expose the tooth, and minimum force to section and elevate the tooth. So he cautions us against applying too much of an elevation force to get the tooth out. But then in the same article, the case against doing both procedures together was by Schwartz. He highly recommends doing the procedures at least 6 months before orthognathic surgery. Because in a case like this, if you split and try to remove the tooth, the bone on the lingual aspect is so thin that it can fracture off. The chances of unfavorable splits are more. Coming to a recent review by Dr. Balaji, he reviewed his own cases and put a few points together. An impacted third molar below the external oblique ridge, a distoangular or vertically impacted tooth with divergent root would cause more unfavorable splits. And in his review, he saw that bad splits happen more when the impacted tooth is below external oblique ridge. That is, deeply impacted teeth will cause more amount of bad split. This is a picture taken from his article. So in a tooth which is either buccally or lingually impacted, when you try to do a split, you can see the bad splits happening. Same goes true for the multi-rooted teeth as well, because the bone on the buccal and the lingual are going to be thinner because of the multiple roots. But whereas a single root which is impacted above the external oblique ridge, which is positioned, is not too deep an impaction, you can do a procedure. So here I would like to hear from Shruti what her opinion about doing both procedures together or as separate ones. Shruti?
Yes, ma'am.
Yeah.
Ma'am, I recently came across this article about the third molar, wherein they recommend that it's better to get it done in a single sitting, because they don't, patients have to go through double admissions, 2 turns of, the stress of 2 surgeries with equal amount of pain, swelling, and other complications, 2 rounds of antibiotic. And as such, when they evaluated the time difference, they said, when you didn't have to remove the third molar in BSSOs, it came to around 118 minutes.
Oh,
And
okay.
with the BSSO, with the third molar removal, it came to 124 minutes. So even the time taken was not too different.
Yeah.
This is the article by Morton and Downey, which came in the year 2017 in B. Jones, ma'am.
Oh, okay.
So this is what I thought I should share with you.
Yeah. Thanks for sharing. Like Shruti was saying, one good factor for removing both together are stress of two operations from the patient's part. But then in the decision will have to be taken by the individual who is going to do the surgery. There is no tailor-made answer for the question. See, two cases. One is of a mandibular deficiency and one is of a maxillary deficiency. Both are young girls with impacted teeth. This is the girl with the maxillary deficiency and this is with mandibular deficiency. The third molars are impacted because obviously they are young girls. But then will you do a simultaneous procedure in this girl of a hemifacial microsomia where the left side mandible is already affected? It is small, narrower and shorter than the other. And then there is an obvious antigonial notch also, which will further reduce the bone stock. So maybe for this girl, I can do both. I can club both procedures together. But for this, I will be happier if I can do the third molar removal earlier. Wait for bone to form. Confirm that bone has formed and then only go ahead with the mandibular procedures.
Wonderful.
Yeah.
Thank you so much.
Welcome. Coming to the next important anatomical landmark, which we have to be careful or important surgical anatomy is the inferior alveolar nerve. You get a lot of imaging done, lateral care for OPG, or in some cases, we get to take CT scan also. Always note where the position of the nerve is going to be with respect to your osteotomy. We'll deal with the inferior alveolar nerve in subsequent slides. And make a diagnosis or make a note of pre-existing TMJ issues and always warn the patient the possibility of worsening the symptoms. Here again, I want Shruti to come up with whatever literature she has come on TMD and the mandibular procedures. Shruti? Hello? Hello, Shruti, are you there?
Yes, sorry, I had not
Yeah.
I had muted myself.
Yeah. Oh.
Yes. So coming to this beautiful article again, which talks about patients with pre-existing TMDs. This came in the American Journal of Orthodontics and Dentofacial Orthopedics, and they say that you don't advocate BSSO for correction of a TMD or for solving the problem of a TMD, but they observed that more patients who had pre-existing TMDs got relieved of their signs and symptoms or saw an improvement of the same after the BSSO.
Okay.
So I think that probably because of the change in our occlusive forces,
The normalization of the occlusal forces, yes, I would agree.
probably that.
Yeah.
The exact reasons are not cited in the article. However, it's definitely an eye-opener.
Yeah. But then always...
one perspective.
Yeah. Always kind of make a comment to the patient about the possibility of worsening, either with the pre-surgical orthodontics or with the surgery, which will settle down in due course of time. But then patient will have to be made aware of this issue. Otherwise, the patient is going to be perennially unhappy or complaining.
Latha, can I come in for a minute?
Yeah, please, Dr. Rama.
Dr. Anisha says that beginners should remove the third molars beforehand. She feels experienced surgeons can do what?
Yeah. No, that is very much true because no, sometime you cannot predict how the third molar is going to behave. It may not be easier to remove a third molar during the surgery of a mandibular split. And then once you gain confidence with your BSSO split, then it becomes easier to manage. And even if you tend to get a bad split, you will be able to manage it if you have gained experience and if you're more confident. So for a beginner, I would always advise to get the third molars out.
Okay, ma'am.
Yeah.
Okay, ma'am. Another quick query in relation to the third molar. Dr. Shruti Gunashekar says, if the third molar is removed during surgery, is there any difference in the profile of the plates that you use? Like, do we have to use higher profile plates if you remove the third molar?
If you feel that the bone has reasonably weakened because of your third molar removal, then it is better to go for sturdier plates. It's not the profile which I would mean, but it's the sturdier plates. You need better fixation, good fixation actually. You might have to go for a double plates.
Okay.
Yeah.
So we'll come to more of that when you do fixation.
Yeah, we'll come to.
Okay.
Yeah.
Okay. Yeah. Ma'am, another quick question before we move forward. I know this is not the planned question break actually.
Yeah, no problem. No problem. Yeah.
We have a question saying, ma'am, how to manage the increased lower facial height in mandibular advancement?
Increased facial height, we have to find out because of what reason the facial height has increased. Is it a pre-existing one, or that starts from the planning stage. You have to make up a good diagnosis as to where the fault lies. The lower facial height can be increased because of the vertical excess of maxilla also. Hello. Yeah.
Yes, Latha, yes.
Yeah. So
Yes,
it
ma'am.
might be a bijou procedure which the patient might require. And then after it's a pure mandibular advancement, and then if you feel that the lower facial height as in the chin is what is kind of bothering, you can always do a genioplasty, reduction genioplasty. Yeah, and then it starts from the planning stage. You get your plan right.
Okay.
And like what we did for the KEF tracing, you can do a manual tracing and then try to see how the profile is going to look with the mandibular advancement alone. And then if you're unhappy, then plan for a genioplasty and again cut a piece of paper and try to advance the chin segment forward, up, or then play with it.
Okay, ma'am.
Yeah, then you'll come up with a treatment plan.
Okay, ma'am. Right. Thank you so much.
Thank you. Proceeding with the planning, we have done the planning, we have done the diagnosis. Now we start the treatment. Pre-surgical orthodontics. Plan with your orthodontist what is it that you're going to do. But here again, warn the patient that she or he may look bad during the pre-surgical orthodontics because the deformity which they had is going to worsen because of the decompensation. Again, have multiple combined clinic in between, repeat visits, records. Keep your records. This is our orthodontist, Dr. Sherry's records. And each time a new patient or each time the patient comes, you see the notes he makes in that. And he keeps the wires change also in a pouch. Always maintain the first cast which you have taken. You might have to go back and see how it was before you started off. This is our record room. It's difficult. It's a space occupying lesion, our hospital usually calls it, but maintain the cast of all your patients. In between, you might have to repeat cast and see how the arches are getting coordinated. You can keep one box per patient in which the pre-strap up or immediate pre-surgical and post-surgical cast will go. So easier to locate for your nurse or assistant the boxes. You have done your pre-surgical orthodontics, both you and your orthodontist are happy. Now you proceed with the surgical plan. Get a model surgery and splint fabricated. So a model surgery has been done. It's a case of maxillary bijou surgery. It's an intermediate splint. Maxilla has been advanced, a splinters in position. It starts from impression taking. Most of the time what we see is impressions taken with the arch wire in place. Usually the impression material flows around the arch wire and causes undercuts, and when you try to remove the impression, it kind of tears into pieces and then comes out. There can be a lot of distortion happening. So for your model surgery, take the impression with the arch wire removed, or after you block the undercuts with wax. The impression, like I said, can be distorted. You may keep the impression for too long before you pour a cast. the bite the patient gave you could be wrong. It might not be his most natural centriculation or centric-occlusion. It could be either mandible advanced or mandible retruded kind of bite he can give. You can go wrong on your Facebook transfer. You can do the articulation wrong. And after you made the splint, there could be a lot of acrylic interferences with the bracket when you try it out on the patient during the surgery. And in the end, you might not be able to use it. So always check the fit of the splint before on the previous day of surgery, unless it is a segmental surgery. Segmental surgery, of course, you will not be able to check the splint pre-operatively. But maxilla, mandible, straightforward, back, or all those stuff, you can check for bracket interferences. And then, of course, poor quality of materials. Or then you have made the splint. Till that stage, everything was perfect. But the splint underwent warpage. So after you prepare the splint, always make sure that it is either put it in water or you keep it in the same articulator, in the same cast. In the same cast like this till the time of, on the day of surgery. And 2 hours or 3 hours before the surgery, you put it into cold sterilizing fluid. So these are one or two of the articles which will be good if the postgraduate students can get hold of and read. It's by Ellis. He gives how or what all things to be checked in the model surgery. And another article by Sang. He again describes the various techniques of model surgery. So we saw a lot of mistakes happening with manual planning, manual model surgery. So one answer to it is virtual surgical planning. And the benefit is given as the increased accuracy with a precision of 1/100th of a millimeter is what is being projected as a USP of virtual surgical planning, which reduces the operating time and patient is highly satisfied with the result he gets. In virtual surgery, you can get the occlusal splint made, you can get a cutting guide, plate bending templates or pre-bent plates. You can see the surgery is planned virtually. It's a bijaw surgery, maxilla has gone up, mandible is coming forward. You can make a splint. This is the cutting guide. You have a slit through which your saw is going to go in. And the cut is going to be precisely at the location where you want or where you have planned in your virtual model. And this is a prefabricated plate. You can see it is the bent, it's a maxillary advancement and the plate, you get bent plates according to it. So this is a 1 unit prefabricated plate for the entire maxilla. And you can see this is a cutting guide in place through which the cuts will be made. And then maxilla advanced and you can apply the pre-bent plate. So the advancement or the movement, what you're going to do during the surgery is already incorporated in the plate. You just need to put it in. And this is a cutting guide for genioplasty and a genial plate. So Figueredo in 2020 gave the advantages of virtual surgical plan. You tend to spend less time in surgery, you get more accurate results, and you get better sturdy plates. Not like our regular mini plates. Since the plates are combined, a big 1 unit plate, you get good stability with the plates. And you can plan the fixation to happen on thick bone. You can avoid the nerve and the roots, and you can control the proximal segment of the mandible. But then there are some issues like you have to spend, there is a huge learning curve. You have to spend more time on planning. Frequent cross-checking will have to happen between you and your technician who does this job. And right now, the cost is a huge factor. You have to see what you are going to gain from reducing the time of surgery. Will it balance this cost off? If yes, then yes, definitely you can go ahead with virtual surgical planning. These are few of the softwares which are there, which are available. It's beautifully given in the article by Dr. Philip Matthew in our national journal. And then few other articles which are kind of good ones for the postgraduates to have a look at it. It's in PRS. They mention what are the difficulties or what are the benefits of getting a virtual surgical planning. And 2 more articles. Why this is again a good beginning article by Polly and Figuera. Okay, we take the next question break here, Shruti.
Right.
Yeah.
Ma'am, just one quick question
Yeah.
is, do you use any software for planning?
Yeah, the software which is kind of available for us is a Dolphin 3D software, where
Okay,
we
ma'am.
can do the 3-dimensional planning.
Okay, ma'am. Okay.
And we can print the splint out. We
Okay.
have reached
So
till that time.
the simulation is pretty good, right? In this
Yeah,
one,
simulation is
it's
good.
good to
It
show,
did,
to
yeah,
discuss
like
with
what,
patient.
yeah, we discuss with patient is like most of the patients would want to see how their face will kind of look after the
How it'll look. Right.
surgery. Yeah, this is a good patient education tool. I definitely agree.
And do you more or less get approximately similar results?
I
Like
think we get slightly more better results than
better
the
results?
software, because in the
Correct.
software, the
Okay.
soft tissue profile, even if you do a 3D, there is a little bit arbitrary touch-ups which we have to do.
Correct.
Yeah.
Correct.
So,
Okay.
yeah.
All right. Ma'am, we'll quickly move forward because actually we haven't realized, but we're sort of running behind
We are,
schedule.
yeah.
Yes.
Okay, so to go forward, we have done the things which we have to look into at the planning stage. Now we are going to the surgical part per se. So surgery, we know we have to incise, we have to expose, do the osteotomy, then fix, and then close. Incision, it can be a incision, a clavicular around the third molar if you have the third molar present, a clavicular incision. Or if the third molar is absent, or if you want to avoid the clavicular incision, you can go a gingiva sparing or a vestibular kind of incision along the external oblique ridge. Here, always keep in mind that the lingual nerve and the long buccal nerves are kind of quite superficial. So it's not like one stroke cut into the bone. You cut mucosa, submucosa, a little bit of blunt dissection, observe or wash the periosteum in the labial aspect, and then proceed. And it has to be a single steady incision. It shouldn't be really jagged or ragged kind of incision, single steady incision. Maintain adequate soft tissue for suturing. This is very important. Leave enough amount of soft tissue. I will say about 5 to 8 millimeter of tissue should be left above the incision for you to close. Otherwise, what happens is when you try to suture and attach gingiva onto the attached gingiva, it will come tearing off. And maintain pedicle thickness. The vasculature, like what Epker said, remains with the soft tissue. A lot of articles are there for the pedicle safety for the maxilla, but I couldn't find much on the mandible. But this is the normal blood supply to our mandible. It comes out through the inferior alveolar vessel. But in cases where the inferior alveolar nerve is occluded or cut, what happens? Then on the labial surface, it is taken over by the facial artery and the submental artery. And on the lingual aspect, it is by the lingual artery and sublingual artery. So you need to have good soft tissue all around. So your retraction has to be minimal, reflection has to be minimal, just enough to get your osteotomy, not too much. And when you do a reflection in the external oblique region, there is the area where the fat is present. You always keep your dissection in the subperiosteal plane. If the fat herniates, it's going to be a nuisance actually. It will keep jumping into your field. And like Epker said, reflect masseters just enough to get exposure and not too much on the entire lateral surface. And as you go along the external oblique ridge up, these are the fibers of temporalis which you will be encountering. Again, those needs to be taken off or dissected off the bone to expose the external oblique ridge. And once you expose, and as you keep on exposing it, this is a forked ramus retractor. You put the retractor, that V notch will rest on the bone and retraction will happen, and you can keep on reflecting on the medial aspect of the ramus. And on the medial side, you have to reflect till the posterior border of the mandible just above the lingula. And one quick note of, in few of the people, the lingula may not be too prominent, may not be like you cannot identify. So an approximate assessment will be like it lies almost at the same point as your sigmoid notches. So that is one way of checking where the lingula could be. And preoperatively, you can check where the lingula is going to be. You can see where the mandibular foramen is, and it is just above and little more posterior will be the lingula. So you can make a mental note of as to how many millimeters above the occlusal plane your lingula is going to be. And expose the nerve if you are happy. I am comfortable by seeing the nerve and reflecting it off. And put good retractors on both medial and the lateral side to protect the tissues. Coming to the inferior alveolar nerve, literature shows that paresthesia with inferior alveolar nerve involvement is more when you do a combined procedure. Of that combined procedure in the sense, BSSO is combined with genioplasty. And the nerve can damage by too much of retraction on the medial aspect. The nerve, as it enters the mandibular foramen, can get stressed. It can get cut during your osteotomy. When you try to reposition the dentate segment, that is the distal segment, either advance or setback, you have to do a little bit of stripping of the muscles. At that point of time, distal segment the nerve can get compressed or traumatized. And then a screw, during incorrect fixation, your screw can enter the nerve or injure the nerve. Literature shows about 12.8% of inferior alveolar nerve paresthesia persist beyond the surgery, beyond 1 year of surgery. So where you usually encounter the nerve is when you do the split. Part of the nerve will be seen stuck to the proximal bone. That is the segment with the condyle. Part of the nerve and the nerve canal will be on the proximal segment. If you happen to see, always observe, this is why it's good hemostasis, good light, do gentle prying with your Smith spreader or instrument or your chisel. You will see where if the nerve is stuck onto the opposite side. Gently relieve the canal. If the entire nerve with the bone is there, you might have to gently break off the bone and then tease the nerve out from the proximal segment. And there was a question as to the osteotome, special osteotome which we use. It's a Daughtry osteotome. When you use along this path, the osteotome you can use is a curved one, though in the picture it looks straight. There are curved ones, and the curvature faces the buccal bone. It hugs like this. I have a picture coming. So as you go down, the sharp edge will hug on the buccal surface of the cortex of the buccal surface, and the nerve will be pushed back into the distal segment. And this shows how many millimeters the nerve is vertically down. This is the cut marked, and this is the height the nerve is going to be. So you can see it's 11.9 millimeter from the external oblique ridge when you begin the oblique cut somewhere here. And as you come forward, the distance of the nerve from the alveolar crest is reducing. And when you reach the first molar, third molar, second molar, it is like 8 millimeter. So always be mindful of the depth your burr or your saw is going to go into the bone. Don't go the entire depth. And this is the mediolateral position of the nerve from the buccal to the lingual. You see, this nerve is kind of mid-alveolar when you reach the first molar region. Behind the second molar, it is more buccal, and anterior to it is again more buccal. So in the first molar region, it's kind of a mid-buccal region.
Okay, ma'am.
Yeah, we take a break
Right.
here
So
for the
coming to
next poll.
question poll 4,
Yeah.
it says, what is the ideal position for buccal vertical osteotomy in Hansak's modification? Is it between the first and second premolar, between the second premolar and first molar, between the first and second molar, or distal to the second molar? I see a lot of people are answering quickly. Yeah, 17%. Let's see it rise. Ma'am, that's been quite a beautiful narration of the course of the nerve and how to take
Yes.
care of it.
Yes.
Thank you so much. Yes. Ma'am, where did you get that picture of the daughtry osteotome? It's an interesting picture.
Yeah, no, we have a better picture coming up in one of the modifications. Yes, I have enlarged that picture and I've kept it.
Very nice. Okay, ma'am.
You know, I'm very bad with names and years. The
That's
technique
fine. No
stays with
problem.
me, but then the name of the author and the year, it kind of goes off.
Oh, that's fine.
Yeah.
Right. Okay. Sir, are we waiting for some more answers, sir? Abhilasha, ma'am?
Just 5 more minutes, 5 more seconds.
Okay, sir. Okay, sir.
Just 5 seconds, and then we are done. Okay, I will share the results.
Yes, good.
Most of them are answered it as option C.
Yeah. So that is the answer. From the biomechanical part of it, we saw in the dry mandible how there is a bulge in the lower border of the mandible, just in the region of first and second molar. That will give an increased strength, mechanical strength as well, if you keep a buccal vertical osteotomy there. And the nerve at that point is almost at midway between the cortexes. So it is the safest place to get a vertical osteotomy done in your BSSO.
Okay, ma'am.
Yep. So that is fall 4. So this is where the bulge is. You can see as you see it from beneath the bulge, and it almost corresponds with the first or the second molar region. That
Fine.
is where your buccal vertical cut is supposed to be. And neurosensory evaluation of inferior alveolar nerve involvement in Wolford technique by Johns gives that no paresthesia persists at the end of 1 year. This Wolford technique will come immediately after these two slides, will come to that. And again, they have done another study in which they do a intra-op checking of the nerve, and they see that maximum disturbance to the nerve happens during the medial retraction of soft tissues. So Wolford cautions us against too much of a retraction on the medial aspect of the ramus. And yeah, this is the daughtry osteotome, which is a curved one, and the curve faces the buccal cortex, and the cutting edge is onto the buccal cortex with a blunt edge against the nerve. So the nerve is protected. And Menzick has come out that chisel usage kind of creates more nerve damage. So when he did a retrospective evaluation, no chisel use group had, or minimal chisel use group had only 4.1% of nerve disturbances. Whereas in cases where extensive use of chiseling was done, the new nerve deficiency or the defect was about 18 to 37%. And this is again that curved osteotome, which is kind of pushes the nerve away from the. Yeah, coming to the inferior alveolar nerve, I want Shruti to share her thoughts on the involvement of inferior alveolar nerve in BSSO. Shruti?
Ma'am, what we'll do is we'll quickly just share the articles with the audience, and I'll ask them to go through it. So basically, we have multiple systematic reviews that have been done on, the post-operative situation with the inferior alveolar nerve, wherein there have been subjective and objective methods that have been incorporated to assess them. And as per right, so most of the assessment is not proper because we do basically a subjective assessment. So what they recommend in this article, uh, that you see on the left, the Journal of Oral and Maxillofacial Surgery article, they recommend that we should do, instead of using just purely subjective methods, that is by questionnaires, we can use relatively objective methods, which would include static light touch, brush, directional discrimination, 2-point discrimination, thermal discrimination. We can incorporate these, as well as a purely objective assessment, which would include trigeminal somatosensory evoked potentials, the sensory nerve action potential, and blink reflex method. So these are some objective methods of assessment which they are advising people to do RCTs on, so that we have a better compilation of literature. So as of right now, this is one. These are a couple of articles that would be good for the PGs to look through.
Yeah.
Ma'am, there is
Yeah,
another.
yeah, we have a couple of more articles.
Yes, in
Yeah.
this they say that when you the neurosensory deficit is more frequent when you manipulate the inferior alveolar nerve. When you see it and dissect it or lacerate it or even just dissect around it, that time you have a greater disturbance compared to when you don't see it at all. So, ma'am, would you
Yeah,
want to go and
yeah.
identify the nerve, or would you just be happy if you don't see it?
If I don't see it, I'm the happiest person. Unless at the point of
Okay.
entry, I don't seek the nerve at all. But
Okay.
then in cases where I club my BSSO with genioplasty, I have to kind of encounter the nerve. I have to see the mental nerve. I might have to dissect the nerve free from the periosteum.
Right.
So like what the
But at the
literature,
mental,
yeah.
at the mental level, mental nerve, I think is more easy to dissect out,
Yeah,
or
it is more easier to,
probably
yeah,
less paresthesia
less
also, because
yeah, but
routinely we're
then
doing it for the
the
fractures.
number of people who get paresthesia is more when we club the BSSO along with genioplasty.
Okay, ma'am.
Maybe
Okay,
because of the manipulation we do at the mental
fine.
nerve level.
Fine.
Yeah.
Okay. And another article that I found interesting was they delivered this low-level laser therapy
Yeah.
to the patients who had post-operative deficit, sensory neural deficit. And they said what they did is that they delivered infrared radiation to the experimental group at about 157 joules per centimeter square to 780 nanometers, and they radiated for about 90 seconds at each point along the external course of the inferior alveolar nerve, as well as at the mental foramen intraorally. So they did 5 sittings of LLLT within 3 to 4 weeks, and they observed that with this the patients did have a good improvement. So maybe we should try out some studies using the
Yeah,
same.
I don't have direct experience with lasers, but then the literature shows that you get a better recovery from the paresthesia with low-level laser therapy.
Okay, ma'am.
Yeah, shall we proceed?
Shall we proceed?
I think we are
Ma'am,
kind.
sorry, just
Yes, yes,
one
you can.
question.
Yeah.
Just one question. If
Yeah.
a patient has a unilateral presentation of inferior alveolar as a bifid nerve with 2 canals continuing in the mandible as independent nerves, how to plan an osteotomy? This question is asked by Dr. Anton Tyrone.
Okay, that is a very good question. We cannot kind of modify too much even if we detect preoperatively two separate nerves. So the option, the idea will be, or the technique will be, do gentle traction, see how it is, and if you can identify, you might have to drill out the nerve, the one or both the nerves out before you proceed with your completion of the splitting. The detection of two separate canals in a regular radiograph, I don't know, I haven't seen one. On the radiograph, I was not able to identify one separate nerve on the radiograph. But when you take a CT and if you play around the CT before the procedure, you see, go through each cut, then yes, you will be able to know. You might have to modify a little bit on the osteotomy, and then you might have to expose the nerve and take it out or something like that. Is that okay?
Yeah, thank you so
Yeah,
much, ma'am.
yeah,
Thank you.
yeah.
Yes. So
Yeah.
for any of the questions, this is another interesting
Awesome,
article,
yeah.
but I'll just request you to take a screenshot and then read it up yourself,
Yeah.
because
So it just
I
says
think we're
that,
running a bit
yeah.
short of
Yeah,
time.
it
Yes.
just says that whatever the pattern of your lingual split, the nerve involvement is going to be kind of same. And
Right.
the nerve deficiency or nerve defect is going to be more or depend more on the distance of mandibular movement which we do.
Okay, ma'am.
And like
Okay,
you said, intraoperatively, if you expose the nerve or you manipulate the nerve, the deficit is going to be more.
Greater, more evident. Yeah. Right. So Dr. Anton Tyrone says, thank you, ma'am, to you.
Okay, well.
All right. So we will
So
proceed.
continuing with that, now we have come to that osteotomy part. There is a medial osteotomy, there is an oblique, and there is a vertical one. And there are few modifications to protect the nerve. The later modifications to protect the nerve. You saw how what do you say, without lower border, the distal part of the distal segment is kind of quite thin. So Larry Wolford is of the opinion that when the lower border is not cut, means not split, here we don't split the lower border. So this portion is a weak area which can give an unfavorable split. So he always advocates the lower border cut. He uses a specialized reciprocating saw for getting the cut right. He calls it the fourth cut in the by BSSO. The first is a medial cut, second is an oblique cut, this is the vertical cut, and the lower border cut is the fourth cut. And you can see it starts from here and proceeds posteriorly till the angle region. This is the fourth cut which he says, the inferior border. The advantage is that you get a predictable split. The maximum force you take is to split the, not to cut the lower border. Like in the vertical, we have to make sure that the buccal and the lingual cortex is cut before you split. Here, you know that lower border is split. So you get a predictable split. The nerve is protected well. It doesn't undergo any pressure. And you don't have to do a lot of chiseling. So it is gentler on your TMJ as well. And since it is, it beautifully splits from top to bottom, the adaptation is very easy and you get a better fixation. And the advantage of the this modification is it's extremely useful in high angle case where your height and the buccolingual width is small. You don't want to put undue pressure on the splitting. So if you have split the lower border also, then it's just gentle spreading with the osteotome is what required. And then there are other techniques to split the lower border. There is a modification of chisel which will go into the vertical cut posteriorly, proceed posteriorly. This guard will restrict how much amount of chisel it can go. It always remains outside. So that is a vertical stop. It will not allow the chisel to dip in further into the bone. Then piezo saw can be used. Piezo again is it's more gentler on the nerve. Then pay attention to the daughtry osteotome, which I was mentioning. This is the article. PGs can have a look at it. Here they kind of take pre-op CT and then confirm where the nerve is, then proceed. And they use a daughtry osteotome, curved daughtry osteotome, and they call it a twist maneuver. The nerve is identified and marked. They proceed with the saw cut and then use the daughtry osteotome and then do a little bit of twisting action with the osteotome itself. And this is the chisel facing the bone. And it is much gentler on the nerve. And then there is one small article, modification, a technical note rather. Rather than keeping the lingual split above the lingula and taking it midway or beyond the midway, these authors have done the splitting or done the medial cut at the level of inferior alveolar foramen. So the amount of the distal bone, that distal overlap is short. So they say that the chances of bad split is less in this case. You can compare it. It's like this is the regular what we do. This is this long bone without the lower border. But whereas in the short split, the unsupported bone or the thin bone is very small. And since the split happens to the inferior alveolar canal, the nerve is undisturbed is what they say. So piezoelectric surgery, Shruti, can I skip on this because of lack of
yes,
time?
ma'am.
Yeah.
What I will do is I'll just give them a briefing. Basically, piezoelectric surgery is supposed to be gentler than the routine surgical technique. However, on studies and systematic reviews that we can see even on the next slide, they are not able to justify this because of fewer number of cases. However, do go through these articles. This is for the postgraduates. Please go through these articles and you will find some important information.
Yeah.
It's probably a way of the future, except for the increased duration that it's
Duration of surgery.
associated.
It's a very slow to cut the bone with pizza, but
Yes.
it has the advantage of not cutting the soft tissues.
Yes, yes.
Yeah.
Okay, ma'am. We'll
Coming
move
to
ahead.
the bad split. An unfavorable or unanticipated split, other than what is there in that classically described BSSO, is called a bad split. It can happen anywhere on the buccal shelf, on the ramus, on the lingual side. So the incidence is like 0.2 to 11% by various authors. And this article gives the predisposing factors. This is a beautiful article in IJOMS in 2016 by Steenen. He says with increasing age, you get more bad splits because the cancellous bone reduces in advancing age. And the splitting technique, the Dalpone technique, has the least amount of nerve. No, sorry, this is in the reverse. So Dalpone has the maximum amount of nerve damage, whereas Obegesser is the maximum nerve-friendly technique. Then presence of third molar, they didn't find much difference in bad splits. Then incomplete lower border osteotomy gives a high amount of bad split. Then medial cut, if you have placed the medial cut not at the lingula much above, what happens is the fracture passes through the coronoid notch and the condyle or the coronoid can separate out. Be very gentle with the force you apply. Do not use chisels extensively. So it's just like it can happen. It can go through the foramen. If you detect as it happens, most of the situation you will see the bad split happening. If you see it happening, stop. Gently modify. If the piece has been separated out, you can tie it with wires or screws, and then proceed. See, the coronoid process has separated out from the condyle. You can have a lingual cortical fracture if there is an impacted tooth. The condyle can fracture off. This is an article in Telsro. Just go through these articles. And this is one of two cases where we had bad splits. The anterior portion of the buccal cortical portion came off. So you see, we had to use an additional longer plate to immobilize it. Another case where we had a separation of the condyle from the, no, not the condyle, the angle portion from the proximal segment. Yeah, you can see it very well here. The proximal segment, the distal segment, the angle portion separated off. So prevention is always better. Diagnose early, you see the bad split happening. You can always see the bad split happening. So modify your technique, be gentler, and surgical steps has to be followed very meticulously. And what happens with the fractured piece? Most of the time it takes, well, it revascularizes, but sometimes it can necrose and pop out through the oral tissue or through the neck. Now you have done the splitting. Now you need to reposition the distal segment. Distal segment is the segment with the tooth. Okay, so when you have to posteriorly reposition, you might have to relieve a little bit of pterygomesenteric attachment so that your posterior movement of the distal segment is easier. Otherwise, what happens is if you try to do it without stripping the muscle off, the muscle will push it forward. So you strip a little more than required. And this article gives beautifully how the posterior, this is like we are trying to posteriorly place the BSSO segment. The sphenomandibular ligament and the medial pterygoid is what is going to interfere. So you can either strip these muscles or soft tissues off, or they advocate an osteotomy. Just cut. After taking protection of the nerve, just cut beyond the portion of the bone beyond the second molar and leave it there. Do not remove it, just cut it off. That's it. Then you are free to do the movement. And this is the lingual cortical cut, which can be seen on the radiograph. So this technique comes useful especially in anti-clockwise rotation or counterclockwise rotation of the maxillomandibular case. This is a boy with short ramus mandible with maxillomandibular retrusion. This is the occlusion he came with. It's like almost kind of a good occlusion. But on the lateral calf, you see how far behind the from nasion the maxilla and the mandible is situated, and you can see the airway. So here what we have done is we have done a counterclockwise rotation of maxilla and the mandible. And you see how beautifully the airway has opened. In this case particularly, we might have to cut the distal moat portion of the dentate segment so that we'll be able to reposition the dentate segment in the position. Yeah, next issue is condylar sag. Epker explained the condylar sag as like proper positioning of the condyle in the fossa is very much essential to get a stable result. And if your condyle is not perfectly seated in the fossa, immediately after the removal of the intermaxillary fixation, you will see that your occlusion is changed. So the condylar sag is a change in position of the condyle, leading to a change in the occlusion. It's a small video, animation. Let me check whether it plays. Yeah. You have cut the done a BSSO, and while trying to fix, you are pushing the condyle back, but then you might relax a little bit, and you have fixed the condyle in an anterior position. So when you remove the IMF, what happens? The condyle goes back in. I'll play it again. So BSSO is performed. You have put the wafer in. You are repositioning the condyle and trying to put the plate. You are repositioning with an instrument and a digital pressure. But sometimes your assistant may relax a little bit. So the condyle is still distracted. So when you remove the wafer, the condyle goes back, leading to an anterior open bite and malocclusion. It's a good study by Reineke. He did a prospective study in 184 BSSO advancement cases. That's a huge number. And he explains the condylar sag as a central and peripheral one. In the central, when you do the fixation, means when you do the intermaxillary fixation and plating, your condyle is dragged down and forward. It doesn't contact any of the bone anywhere in the glenoid fossa. It is just down and forward. So when you remove the wafer and release the occlusion, the condyle goes back into its normal position and malocclusion develops. This is the central type of condylar sag. Then there are two types. This is like how the occlusion is going to be if the central sag is on the bilateral side. You can see the article. It's a good article. They are explained it well. And there are two types of peripheral sag also, type 1 and 2. Type 1, your condyle is positioned inferiorly, but it is touching one of the walls on the fossa. Here, the condyle may not go back to glenoid fossa when you release the IMF. The occlusion may remain stable, but it is hitting against the fossa somewhere. And that portion of the glenoid fossa and the condyle can undergo resorption or remodeling. And gradual change in occlusion can happen. This is a delayed occlusal relapse is same. Whereas in the peripheral condylar sag type 2, condyle is in correct place when you are put it into IMF. It is passively sitting in the glenoid fossa. But when you try to fix it, you might distort or force the condyle a little bit this way or that way. And so when you release the occlusion, what happens? The condyle tries to go back to its normal position. And the occlusion can change. Again, the pictures. So how will you control the proximal segment during fixation? You can fix the proximal segment to stabler either maxillary tooth or a stabler portion of buttress. These are the techniques which were used by Leonard in 1980s. But now with virtual planning, we can print these wafers with devices to stabilize the proximal segment. And you can confirm by intra-op imaging if you have access to it. So just go through this article by Reineke and Ferretti. And they say what to be done, whichever is possible. It's like this is easily doable thing for us. So when you put it into IMF and then try to plate, you have an instrument pushing the proximal segment posteriorly, and your assistant from external on the angle region is giving a upward force. So that will seat the condyle in the fossa, an upward force on the angle and backward force from the anterior portion. And then can you see two marks? He advocates making two lines on the portion, on the mandible, either with a pencil or with a burr. You just score and make a straight line so that you know when these two lines are aligned, you know that your condyle is in the most positive. These lines are marked before splitting the mandible. So you know this is where it should be. So posterior force on from the anterior end and upward force from the angle region. So then there is, Wolford again came up with a modification to deal with this difficulty in controlling the proximal segment. He modified the cut after the external oblique ridge. He gives a step to the cut. Rather than coming straight like this, he gives a step. So when the mandible is advanced, your proximal segment cannot get displaced because it will hit on the step and it will remain intact itself. So this is how it's advanced. In the setback, you might have to remove bone because of the stepping. These are the regions where you might have to remove the bone. But in the advancement stage, this makes real sense. The condyle, we have an additional guide as to see whether the proximal segment is in place. Yeah. Do we have any questions at this point of time, Shruti?
Ma'am, just
Sir,
one quick.
Yeah.
Yes, sorry to interrupt. Can we take it immediately with the polls, the last poll?
Yeah. Please. That will be better. Yeah, we are really running short of time. Yes. Yeah, we'll do that. So passing on to the intraoperative bleeding is something which we wanted to have a word with. So what we usually do is our anesthetist gives us good hypotensive anesthesia. And then when you do the procedure, you remain in the subperiosteal plane. You do not go out of your periosteal plane. So if you puncture your periosteum and go out, your muscles can bleed and your important vessels are quite near to your posterior border of the ramus. And for the bleeding, local measures like Surgicel or Abgel can be packed. And sometimes the anesthetist might be happy in giving intravenous anesthesia also. This is a case report where there is a bleeding, massive hemorrhage following a BSSO split. And you can see the reason in this article. They have done an anatomic study and showed how close the retromandibular vein and external carotid artery is to the posterior border and the area where we are going to cut. This is the maxillary artery, this branch. This is the external carotid, and this is the retromandibular vein. So always remain within the subperiosteal plane, and you do not perforate and go beyond when you do a dissection on the posterior aspect. So again, a lower border stepping is something, Shruti, would you like to say, or shall I say and pass?
Ma'am, you quickly take it now. Yeah.
So in the Hansak modification or in the technique which we do, sometimes patients may feel a defect in this region where the lower cortex is missing, this portion. In most of the patients, they don't see or feel it at all. But some curious patients, when they do palpate their lower border, they'll feel this. This is like if they are, I don't know, the literature says that you can do bone graft, either autograft or allografts can be used to mask that defect or the stepping. But then in my experience, we have never used any bone graft in that region.
Correct. In fact, I think even the more recent articles, they've studied xenografts, but we don't know whether it's really required or not.
How they will behave in the long term is something which we don't know.
And in fact, they've described one technique in which they're saying don't cut the lower border completely. You maintain the lingual plate intact. So that way your defect will be less. But somehow I think I've always cut the lower border completely.
No, lower border you come unless you have some sort to cut your inferior border, split the inferior border. If you are doing a regular osteotomy, you always cut the both cortexes at the vertical. Otherwise, you are going to have a bad split.
Yes, ma'am.
Coming to fixation. We started with like wire osteosynthesis, progressed into mini plates, and then we came into rigid fixation with 3 lakh screws or positional screws. And now we are into pre-bent plate or prefabricated plates or printed plates. When you apply positional screws or lag screws, it's like it has to be in a line, all 3 on the upper border, or in a triangulated fashion, 2 in the upper and 1 in the lower. Or if you're using plate, if it is a setback, I would say that you might get away with a single plate. But if it's a huge amount of advancement, it's always better to put 2 plates. And the screws on the lower plate can be bicortical. One or two slides on bicortical screws. Bicortical, as the term says, it pierces both cortexes. It can be either lag screw or positional screw. In the lag screw functions with the principle of compression osteosynthesis. It provides a rigid fixation and compresses both the cortexes together. So you have to be highly sure that your position is right, everything is right before you apply this compression. Otherwise, your condylar segment or the distal segment may jump out. Whereas the positional screws, though hold both cortices together, it doesn't compress. It doesn't put too much pressure across the segment. So you can see this is a positional screw. Can you see the cursor moving? Hello?
Yes, we can see Latha. Yes.
Ma'am,
This is the positional screw. You see, the segments are held in place, not compressed against one another. They are just passively holding both segments together. Where this is a hybrid technique where plate and screws are being used. This is again positional screw. But when you come to lag screw, there is a basic structural difference in this. A normal screw, this is a lag screw. It doesn't have thread in the upper part. So when you drill a hole and you put a screw in, the screw in the upper hole or the, say, in the cortex nearer to you will glide through it. Then it bites into the inner cortex. And then it will start pulling the both cortexes towards one another, each other. You're understanding, right? It glides through the first hole, first cortex. And then as it starts biting into the inner cortex, the cortex is pulled towards the first cortex and they are held in a compression together like this. This is the basic principle of lag screws. AO surgical reference site gives beautiful pictures and videos of the lag screw principles. Just go through them, you'll understand better. And a small video. Do we have time to run this video?
I think, yes, I think quickly you
can. Yeah, it's just 5 minutes and then I have 2 more slides, then we are done. So,
okay, no problem.
Yeah. So like I said, we start from the labial aspect, you hit the bone, get good hemostasis, and always remain subperiosteal plane, in the subperiosteal plane. And this is the forked ramus retractor that is going in, retracting the tissue, and I've jumped onto the other side. It is difficult to get a perfect video. And you can see that I am reflecting the temporalis muscles off, fibers off, and my plane is in the subperiosteum. You see the periosteum going in. I'm never ever away from the subperiosteal plane. I'm reflecting the temporalis fibers off, and I'm going on the medial until the posterior end will go. I'm marking the and then anterior reflection. Yeah, see, the periosteum is not torn, it is intact. I'm in the subperiosteal plane. And as I reach the first and second molar, the vertical osteotomy is marked. And we start from you can use Linderman burr or this is a regular normal SS white burr, tungsten carbide. You can see the osteotomy being done. Here, this is a channel retractor which has gone and secured on the posterior border of the ramus. This will pull the medial tissue away from your burr. And we do postage stamp technique. It gives better control for your osteotomy rather than a freehand running. Then you connect the dots and then you come onto the buccal. And as you cut the lower, as you go near the lower border, this reverse LB, reverse Langenbeck or toe out as it is called. it reflects the tissue away from the lower border.
Ma'am,
Here
would you
you-
ever use a channel retractor at this point?
Yeah, it can be a channel,
Okay.
the medial, this is a channel retractor which is pulling down the medial tissue.
Correct.
See here, the reverse LB helps you to
On
get
this
the
side. Inferior
tissue,
border cut.
inferior border correctly. Because it is short, it is easier to apply. Here, channel will be a little too long for here.
Yes, yes.
And you connect the dots. Yeah, here all around, I'm very sure that I'm very cautious that my burr doesn't go beyond the cutting head depth. It doesn't go deep and cut. My cut is only the burr head depth, that is all. And when you cut the lower border, you can pull on the tissues away and then cut.
Ma'am, you have your irrigating solution coming in through
we
the
have a
handpiece.
pump. Yeah, we have a pump to which the
Okay,
micromotor
okay.
handpiece can be connected.
Oh,
And,
lovely.
yeah, it can be operated with a single foot pedal. Yeah.
Wonderful,
This
wonderful.
is the channel retractor, which is going and hugging the posterior border, and my tissues are protected. I'm gently using the chisel, small chisel, and I check for the movement. Everywhere I check for movement, I get good hemostasis. Though the hemostasis is not too good in this video, we need to have perfect hemostasis to see where you have more cortex to. Yeah, it's like this is a daughtry osteotome, curved osteotome. And then we apply the Smith spreader. It's like just 3 digits pressure, that's all. So we are starting from 1 and going all around till C where resistance is felt. And then, yeah, gently, and the mandible is
Beautiful.
split. Yeah.
You can see that movement. We
Yeah,
can appreciate it.
appreciate it. And here there is this is the nerve. This is stuck onto the proximal segment. So it is gently being teased out of this is the canal. Part of the canal came onto the proximal segment. This is the nerve. It is being teased out of the bone, and it is being pushed to the distal segment.
Fine.
Yeah. And then we apply the splint. And before you do the fixation, if you're planning genioplasty in this same patient, it is better you mark the genioplasty and then do the plate fixation. Otherwise, most of the time what happens is you fix the plate. Then you will realize that the plate is in
Part
way
of the
of your
plate is
genioplasty. Yeah.
on
So you
the
mark the
line.
genioplasty and see. We use a transbuccal approach for putting the screws on the proximal segment.
Okay. That is another question I had in mind.
Okay.
Because, ma'am, do you normally use 2 plates? You use
Yes, if
a
it is an
single-
advancement, yes, we use 2
plates.
plates. Definitely we
Okay,
use 2 plates
Okay,
because it
ma'am.
gives more stability.
So in
And-
that case, for
yeah.
both the plates for your proximal segment, you use the trocar,
Yeah,
transbuccal
because
approach.
with transbuccal, you can apply the screw perpendicular to the bone, not
Correct.
angulate and put. And the
Okay.
anterior
And
screws
ma'am,
yeah.
Would you want to have them monocortical or bicortical, ma'am?
The lower border is bicortical always,
Okay, ma'am.
and the upper plates are monocortical.
Fine.
Yeah. So this
Ma'am,
is
do you normally place like 2 screws initially on the proximal segment and use that to manipulate?
There are different people doing differently. One of my sirs used to say that we put 2 screws on the proximal segment first and use the plate as for positioning
Anchor
it.
to position it.
Just like a
Because,
pulley.
I
but
had
then
a conversation with
there
Dr.
is another
Pramod
person who
Joshi.
says that the anterior screws can be put first on the distal segment. So the plate will go and hold the proximal segment in place medial-distally.
Oh, okay.
Yeah,
That I haven't heard. Yeah.
Yeah, so
All right.
it varies for
Different thoughts.
Yeah,
Yes.
different thoughts.
Different
All
thoughts.
you have to
and-
make sure is that your assistant applies a gentle pressure on the angle and somebody else is pushing the cortex back with an instrument, which
Fine.
is the occlusion. Yeah, that is it. That is the video.
Fine.
Yeah. Sorry. Yeah.
Beautiful video, ma'am. Thank
Yeah,
you for sharing
thank
it with
you.
us.
Yeah. Shruti, quickly, I give you 30 seconds to go on the
Right.
antibiotics.
So
Yeah.
we had this discussion about antibiotics post-operatively, and there have been studies in which they give just a single dose of pre-op antibiotics, and compared it with, an extended 3 to 5 day course of antibiotic postoperatively. And there are multiple meta-analyses done on this subject, and all have concluded that there is an added benefit of giving postoperative antibiotic therapy. Ma'am, what do you do? When do you give your
We
antibiotic?
give antibiotics the regular 5 days course because the
5 days
patient
course,
stays
yeah.
in the
I
hospital.
think
We
the
don't,
same thing even
yeah,
we do, yeah.
yeah,
All right, ma'am. We'll switch on to the next. We'll
yeah,
move further.
yeah. And
Right.
coming
So
to the
here we
fifth
are
question, yeah.
with poll 5. Sir, time for poll 5.
Hey, Dr. Rama?
Okay, so let
Yeah.
me quickly read the question.
Hello.
What?
Yes, I'm trying to launch it, but it's not happening.
Oh, okay.
Okay. So what we'll do is I will just read it, saying what are the causes of relapse after BSSO advancement? Is it the suprahyoid muscles? Is it
Oh,
mouth
yeah.
bleeding?
Okay, it's
It-
done.
Brilliant. Okay. Is it pressure from the tongue, or is it the pterygomasseteric sling?
Actually, the number of people have, I think the orthodontists left after the treatment planning.
Oh, they missed the video. So if any surgeons have logged out in advance, then
Yeah.
they certainly missed the best part of the talk, which was the surgical video.
No,
So
actually, the issue was that the
Yeah,
waiting
yeah.
room got full for a very long time. So
Yeah, no, I know, I
to
know.
watch it
yeah.
on.
It's like Dr. Rama told me one of us maximum I have taken already 2 hours. 2 hours and little more extra. Yeah.
Yes.
No worries. I
Yeah.
think it's nearly
Yeah.
done.
In the last 1 or 2 slides, that's all.
We're
Okay.
almost done. Yeah, almost there.
I think poll is also done, sir.
Yeah.
We can
Okay.
end the poll.
Oh, people
Yeah,
are still
52%.
voting, I think. Okay.
Ah, yeah, 52%.
Just 5 more seconds. Stop it.
Come on, touch 60. We've been doing 60 right through. Okay.
Think it's
I
stopped.
think we'll. Oh, yes. Okay. Good.
60. Read 60.
Is
Okay.
there results?
Yes. The
Ma'am, your
answer,
comments.
yeah. The answer to this particular question is with advancement, the relapse is commonly because of the posterior pull of the suprahyoid muscles. The muscles cannot beyond a certain limit relax and allow the bone to remain. They try to pull the mandible back after an advancement. If it is a setback, then definitely the pterygomasseteric sling will be the one who will be pushing the mandible forward. Okay, so quickly on to the last part of my talk, stability and relapse. This says it all, which all procedures are stable, orthodontic surgeries procedures are stable and which are less stable. There are a lot of studies between comparing the bicortical screw fixation and monocortical plate fixation, and majority of them show no significant difference between the mini plates and bicortical screws. Statistically significant differences between mini plates and bicortical screw, whether it is an advancement or setback. Again, the factor which contributes to stability here is the amount of advancement or setback. If it is too much, then you are going to have problem with stability. And this article by Joss gives nicely the factors which influences the relapse. Mandibular advancement undergoes a lot of relapse. So they have provided predicting factors which we can give a clue as to whether to expect relapse or not. The amount of advancement takes the first seat. Comes the type and material of fixation. Because if you put too less screws or not too rigid plates, you may have a chance of relapse more. And low and high mandibular plane angle. The low angle will relapse more in the vertical plane because the mandible is closed like this and these muscles are very strong. So they will relapse in the vertical plane, and in the high angle mandible, the relapse will be in the anteroposterior direction. And the proximal segment, you have to have good seating of the condyle in the fossa. Otherwise, you will have a condylar sag and relapse. The soft tissue muscles play a big role in the relapse, like we have already seen in the poll. And if the patient continues to grow, whatever results you have got will go wrong. But can you call it a relapse? I don't know. But yes, the results may not be age and skill of surgeon they have put as the last factor in influencing the relapse. I would say the amount of advancement or the amount of posterior replacement is what determines the relapse the maximum. So if you have a huge amount of either advancement or setback that needs to be done, always consider dividing it between the jaws. Yeah, questions? This
Right.
is the last.
So the key would be to have a bi-jaw osteotomy when you feel
when you feel too much of a
too
difference
much
has to be
change is
maintained, or
required. Okay.
otherwise like what Divya ma'am has said in her talk on distraction, consider distraction also.
Consider distraction.
Yeah.
Wonderful. Okay. So coming to one question by Dr. Chinnai Rajendran, he says, please tell about short lingual split.
Okay, that is only one article which mentions the short lingual split. Here they attempt to take the medial cut or the splitting through the inferior mandibular foramen and the inferior alveolar canal. And the unsupported or the distal portion of the dentate segment is short because the cut is not high on the mandibular ramus, it is low. So they say that I couldn't find any more article on that except for that one, and no more studies also. So I can't comment much on that. According to the authors, they say that the bad split incidence is less.
Okay.
And it is just a difference between the making the medial cut from above the lingula to below the lingula.
Fine. Okay, ma'am. Ma'am, one question from Dr. Shruti Gunashekar. She is still asking, the nerve has to be on which segment, the distal or the proximal?
It has to be on the distal segment. That is the segment with the teeth, dentate segment. The nerve comes with the dentate segment.
Right. Okay. Ma'am, do you feel that a greater amount of technique is required for placement of a lag screw?
Yes, this very technique sensitive.
It's very technique
It's very
sensitive,
technique
right?
sensitive. You have to get it right, one shot. Because
Okay.
there is no trial and error. Like
There's no
the
chance for
mini plate and screws, which allows us a little bit of inclining and all that. That freedom is not there with lag screws.
Okay, ma'am. Ma'am, and what fixation would you use in which situation? Do you normally use mini plate? You told us when one and when two plates.
Yeah.
But we wanted to know, do you use positional screws
Yeah,
and when?
sometimes yes, positional screws, but most of the times it is a mini plate with bicortical screw on the lower border and monocortical screws on the upper border.
Right. That's wonderful.
With transbucal approach. Yeah.
Okay, ma'am. All right. Abhilasha, ma'am, any questions on YouTube, ma'am?
Yeah, no. As of now, no questions on YouTube.
Yep.
All right.
Yeah. So that brings us to the end of our presentation.
Wonderful presentation, Dr. Latha.
Yeah. Thank you so much.
I would like to thank two wonderful women who helped me with the presentation, Dr. Vandana Shenoy from Chennai and Dr. Shruti Rao. Thank you, dears. And then thanks, dear team CIOMS and the audience too.
Thank you. And I've requested Rama sir to allow me one sentence too.
Yeah.
I want to say that thank you is a very little word, but it has a whole world of appreciation in it. And I would like to thank Shenoy sir, Varsha ma'am, Vrinda Kolte ma'am, Madhumati madam, and Abhilasha madam. And definitely our speaker for today, Latha ma'am. I think for me, this has been a wonderful learning experience. Thank you so much, CIAOMS.
I think it was one of the most well choreographed events, right? It was going so much in tandem that you did a great show. Thank you so much. Thank you, Dr. Latha. Thank you. The Raos excelled.
Yeah.
Thank you so much.
Thank you.
Vandana has always been with us. On the presentation.
Both of them were wonderful, speaker and the moderator as well.
Yeah.
Yeah, I agree.
Fantastic job.
Yes.
Fantastic.
Both Dr. Latha and Dr. Shruti, you had a very good coordination. And Dr. Latha, your presentation was very vivid and excellent.
Thank you.
Including your slides for fillers, your own
Yeah.
photographs.
Yeah, my own photographs. Yes.
Yeah, they were also very good.
Thank you.
Beautiful, beautiful presentation.
So this is our webinar team. Next one, Shruti. Yeah, that is, sorry.
Yeah.
This is
This
by
is,
Abhilasha, go ahead.
yeah. This is our upcoming webinar tomorrow 11 a.m. Please join us back. It will be on malunited fractures of the maxillofacial region, COVID time malunion galore. Please don't miss it. This will be by Dr. Ilavanil. So 11 o'clock, stay tuned. And this is the QR code for the CIOMS YouTube channel. Please subscribe to our YouTube channel, as well as please don't forget to hit the bell icon so that you can get all the notifications, whatever videos are being uploaded on the YouTube channel. Thank you.
Ma'am, I'm so sorry. We have a few more questions. So what do we do about that?
I think you can take one or two.
Yeah,
Can
take.
I? Okay. So Dr. Chinnaya Rajendran asks, is Latha ma'am still here with us?
Yeah, I'm here. I'm very much.
Yeah, she's there.
I'm there.
So Dr. Chinnaya Rajendran asks, did you need IMF after fixation?
No, never.
No.
Unless in case where I had bad split, that was a hefty chap, but it was not IMF, it was IME, intermaxillary with elastics. Just so that it's a reminder for the patient actually, so that he doesn't open too much, he doesn't tend to eat something. So
Okay,
just
at
as
this
a
point, I
reminder.
would like to just add you, just ask you, Dr. Latha,
Yeah.
just in case if you have a bad split, do you proceed with your treatment, or you wait for some months and then again re-enter?
No, we proceed because once you identify how the split means the bad split has happened, you try to rectify it, try to treat it like a regular fracture. You put a plate, you stabilize it, and then proceed with your splitting of the mandible. It's like going back again in the same region, same amount of tissue reflection. One patient will have to undergo a second surgery, and the second, the tissues will be scarred. It will be more easier if we do at that time itself.
I think I goofed up
One
on
last.
the certificate, but I'll mail it to you.
Yeah, okay, thank you.
No worries. There's one quick, I think, feedback from Dr. Shruti Gunashikar. She says, wonderful presentation, ma'am. Thank you, Latha, ma'am.
Yeah.
And thank you, CIOMS team and Shinoy, sir.
Thank you so much.
Thank you, Latha and Shruti, for joining us. Thank you so much.
Big clap for CIOMS. I have been following your lectures whenever possible. Like I said, you cover the entire spectrum. You try to cover the entire spectrum. So it has been very useful, a refresher course for me as well in many of the courses.
Yeah, by
Thank you for your positive feedback, Latha.
Yeah.
what the wanted actually.
And in fact, all postgraduates have also been actively involved, and we've got feedback from various places that your webinars are really good. I may not be always present online, but I do make sure I go back and watch the YouTube.
Yes.
Sometimes
That's another advantage.
Sometimes we have to go back on the YouTube. Yes.
So this is not the end. Even after the women's webinar week, we are coming up with some interesting suspense again for you. So please stay tuned. Yeah, and especially on the 17th of this month. Don't forget to log in.
Yeah. Okay. Fine. We'll do.
Thank you so much.
Thank you, Kabir sir, Dr. Ashok, who's there with us all the while. He was there during your entire presentation. Thank you, Ashok sir.
Oh,
thank you, sir. Thank you so much, Ashok sir. Thank you.
Okay.
Bye-bye. Thank you. Thank you so much.
Thank you.
Bye-bye.
Bye-bye.
Thank you for joining. Thank you so much. Oh my God.